All right, so please, I'm going to step over here so I'm not blocking the door.
Stopping
Quite
people
makes
from
sense,
coming in.
exactly. Maybe we can get started. So I'm really thrilled that Claire Brindis has agreed to start our CVP seminar series off. As you all probably know, Claire is a professor of pediatrics and health policy. She's the director of the Philip R. Lee Institute for Health Policy Studies at UCSF. And she's a delightful colleague. She's really an expert in adolescent health and health of young adults. She has really started many fabulous and innovative programs at IHPS. She collaborates on lots of things on this campus. We were really fortunate to have her involved in our CHARM grant, the Center for Health and Risk in Minority Youth and Adults, which really focuses on prevention of chronic illnesses in minority communities, focusing on the youth and young adult period. And Claire is going to talk to us about the Institute of Medicine that recently convened a group to discuss the health of young adults, and that's what we're asking her to talk about today. Thank you very much, Claire.
A little bit of a guinea pig since we're setting off this talking series. I would like to make it as informal as possible, just because the slides are available. I have no qualms about getting to the very end. I do want to comment that it's really a pleasure to be here, and also the tremendous leadership that's presented by you and the center. And I've been at UCSF since 1983. I started as a 3-month consultant, and have been here for a long time. Particularly, I won't count math, but I am particularly proud on my ID to show you this very special pin that means a tremendous amount to me, which was started by Joe Castro, who recently left to become chancellor at the California State in Fresno. And the pin shows on it FG2C, which means first to go to college in my family. So Joe began his program to identify faculty who represented first to go to college in their homes and identify students in the various schools who are also first to go to college so that they have a sense of community. And I'm an immigrant from Argentina. I have another Argentinian colleague here who's joining us. And I'm just very pleased to, on an emotional level as well as a personal and professional level, to be associated with this very, very important center. The talk is about the health and well-being of young adults, and it is related to a workshop that was held at the IOM. Next Friday, the proceedings of this workshop are going to be distributed. So I'm not really at liberty to talk about what all the results are, but as a workshop, it was really a convening much more than a report that requires recommendations or recommendations emerge from it. And fortunately, the funding for that major report has recently been generated. So we will be having a full-blown report on, and a committee on the health and well-being of young adults, which is pretty revolutionary because one of the things that I will be sharing with you today is that, experiment here.
Can we make that full screen?
That.
Do you want me to help you with that?
Doctor will help me with that.
Sure.
Thanks. Thank you. So this is the cover of New York Times Magazine, New York Times. And the point here is that there are a lot of images about young adults. And they're called the millenniums. They're called a variety of names. But as I talk today, I'd like you to be thinking, some of you are in that phase of 18 to 29. Some of you recently left that phase. Some of you have family members who are in it. And I think it's important for you to be thinking about this generation who up to now has had very little focus, and yet it's a very important phase in the lifespan and life pathway that we can help, and it's still a very important time for intervention. And many times, I'm a big newspaper reader. I know it's very old-fashioned, but Just recently, in one of those important newspapers called USA Today, a major article on just the millennials are just content to rent. So the article goes into how the economy is impacting this generation and how the traditional pathway of becoming a homeowner is becoming less and less a reality. If you think about your parents' generations or your grandparents' generations, it used to be that even with a high school diploma, they could leave and get a good paying job and be able to afford a home. That kind of American reality or American dream is becoming less and less. And not just for the most vulnerable in our society, but also many of the quote-unquote middle-class generations. So why is this important? I want to now work and talk with you and share with you some of the conversations that took place at this workshop, really beginning to first create for you a profile of what's going on with this generation from an economic and educational perspective. Sorry. Be patient with me in my technology. And to be thinking really about the significant demographic shifts and how that's going to be changing health patterns in the future. To be thinking about what kind of evidence do we have about this group, but also what are some of the concerns that are emerging? Because traditionally, there are concerns about how this odyssey of pathway is going the traditional ways. The linearity that many previous generations experienced is no longer happening here. And some of the concerns are even a movie related to failure to launch. What is happening with this generation that somehow is not achieving the usual traditional milestones of what we in the past define as adulthood? So a major debate or major question is, what should the milestones be in the 21st century? And that's a very important topic for all of us to delve into, because the reality is that that's the new reality. And perhaps it's the fact that those milestones made sense in a previous decades, but now with so many more alternatives that young people may be putting off some of those milestones, but eventually reaching them. So maybe it's a matter that because we're now living into our 80s and 90s, maybe it's not a problem that people are waiting until their 30s and 40s to get, quote-unquote, some of those adult milestones. I'm reflecting on the fact that as I was putting together my presentation at the Institute of Medicine, I had a conversation. I have two grown sons. One of them actually worked with you in the Department of Pediatrics. He's a pediatrician and emergency medicine doctor. And I was talking to him a little bit about this topic. He said, you know, one of the challenges is it's not just that you have so many options now. It's the fear that you're making the wrong choice. And so you value you look at these options and you're almost afraid of, if I go down this pathway, what will happen with the rest of my life? Am I making the right decision? And perhaps in previous generations, we didn't have as many options to make those kinds of decisions. Demographically, I think it's important to point out that this population, and I'm really referring to both really starting at age 18 and moving on to ages 26. Some of this data reflects 18 to 26, some reflects up to even early 30s. But this population is projected to represent about 10% of the American population. And you can see how the racial and ethnic composition of our society is changing quite impressively, with a decrease substantially in the numbers of whites and an increase in ethnic diversity. And I think it's important to point out that these trends, particularly when we look at Latino populations, how it's changing over the decades. And so these maps show for you, in the same way we use obesity maps in the past, demographic maps, are showing you what a tremendous revolution there has been in the growth of Latino population, particularly in communities all across the country that in the past have not had traditionally those kinds of, those populations, and who are less prepared to provide medical care and quality care. So for example, when Seth was in medical school at Vanderbilt, one of his tasks was to go along with the ambulance drivers, get an experience of going from the ambulance to the emergency department. And He accompanied them, and they picked up a young man who had been in a bar fight. He had been knifed, and there was no one in the ambulance in Nashville who spoke any Spanish. When they went to the emergency department, there was no one who could speak Spanish either, and there was no translation services, and Seth was the one who was asked to do some of the translation, just to find out whether the patient was allergic to any medication, whether they were on any drugs, et cetera, et cetera. So clearly Nashville is just beginning to catch up with some of the expertise that we have in the Bay Area, that we have in New York, that we have in Texas. But I'm just commenting how important these demographic shifts are and how that's going to continue to change the way that the face of America is changing and the kinds of solutions that we have to develop to respond to this population. So clearly, this population is very important in terms of the very long history that we rely upon them to be meaningfully engaged, caring individuals, very productive, and to be really fully engaged in the society. And so there are a lot of concerns right now about, are we going to have this population as engaged into the future? And if they're not engaged, what does that mean? And clearly, certain populations are even more vulnerable about not being engaged, particularly youth aging out of foster care, low-income youth, runaway youth, homeless youth, substance abusing youth. And I do want to make a comment that in the IOM, we really focused also on thinking about the life course perspective in terms of really thinking about what are the opportunities still in the 20s to intervene successfully around tobacco use, around drug use, around food, because it has such a tremendous implication and impact on long-term health. And another exemplar of recent research is an article talking about adolescent and young adult habits, and at only 1%, less than 1% of adolescents in the national study ate what the Heart Association considers to be the ideal diet in terms of fruits, vegetables, etc. So we have a very long way to go, but definitely there's still hope within this age period of having a meaningful way of having it. So let's talk a little bit about the changing context of young adulthood from a social, economic perspective. And I'll touch briefly on employment, marriage, and the role of social technology. As I mentioned earlier, these are the milestones that traditionally have been used to measure adulthood. That is, completion of school, leaving home, financial independence, marriage, and children. Oftentimes in that progression of marriage first and then children. And we need to truly understand the revolution that has happened in our economic perspective in terms of where the jobs were in the past, in terms of industry and manufacturing, and how that's been changing in terms of looking at this post-industrial society where there's so much more emphasis on education and looking at manufacturing and how that's decreased over time, as well as agriculture, which is the blue line at the bottom with the corn sign. So to see that there's been really changes in the way that entrance into jobs, kinds of occupations that are available, has significantly changed. And that we clearly have to recognize the lack of social mobility among this population. That where you begin is oftentimes where you end. And the image of the American dream and bootstraps and being able to move forward has really been confronting our young adults in terms of the lack of entry-level jobs, the lack of opportunities, the lack of jobs that have health insurance, etc. So, in terms of educational trends, the blue line, and I know it's a little hard to you can see that the blue line is at less than 4 years of high school, and that's been diminishing substantially over time. Some college has been mounting, and also the red line being 4 years of high school but no college, that has also been decreasing over time. So we have the schism of very well-educated individuals and populations with many more options, and the populations that have far fewer opportunities for making the American dream work. enrollment, let me try to make this because I know it's a little hard to read. But I wanted to show you the changes between what's happening for males, which is on the top, and females on the bottom. But looking at, when I gave you the demographic profile of Latinos living in the US, you can see the differences between Hispanics in the year 1970, which are the blue lines, red is 2007. So you can see that there's been, among the Hispanics themselves, a little bit of change. Not as great there, but in terms of the differences between the native-born Hispanic and the foreign-born Hispanic, where there's been also substantial changes between females and males. So females, in fact, are now going to college at much larger substantial proportions among Latinos, and changes also among African American whites, as well as whites. And I apologize, or I have to say to you that the limitations are that we don't have data, the same kind of data for Asian Pacific Islanders. Clearly there's been some pretty revolutionary changes in the role of women. When my husband graduated from medical school at Emory University, I received a certificate this large that I had gotten an MRS degree. This is a doctor degree, signed by the dean and signed by my husband. I can tell you that Emory University no longer gives that certificate, but I have that in my office on the same shelf as the award I was able to get from the Chancellor's Office for the Advancement of Women in our campus, which is something of great pride to myself. But there has been a revolution in terms of the number of women in the workforce that all of you are keenly aware of. But in terms of thinking about what's the percentage of individuals who are now in college, comparing men and women, here's a little pop quiz for you. What percentage between the ages of 25 to 29 have completed college degrees? First choice, you can read the choices, 16 versus 28. So is there a vote for the first one? No. The second one? The third one? Third one. And then in what year did this change in terms of women completed college at a higher percentage or rate than men? 1986? 1989? 1991? Or 1995? So it was 1991 is this. But here again, I want to point out to the differences between racial and ethnic populations. And you can see that the purple line is Asian populations, and in the next slide is about gender. And this is sort of when we began to gather data. It's not because I've been trying to cheat Asian Pacific Islanders from looking at this whole line. But you can also see the trend line in terms of percent of adults who have completed 4 years of college. But again, the next is substantial differences between females and males, with more females graduating. Still, concerns are you having a job even when you finish your college degree? And you can know that this is one population that has really been impacted by the recession, and there is tremendous variation also in unemployment levels among the ethnic and racial populations. So one of the challenges about trying to identify and define who these populations are is that all these traditional trajectories have been changing. So people may be dabbling in different jobs, they may be dabbling in different relationships. There isn't sort of a more traditional lines as I've indicated previously. And here I just thought it would be helpful to even see the trajectories in a couple of sort of non-traditional areas. And when you see the report next week, and I'll be happy to send the link to the report, we actually had a representative from the military talk about what some of the challenges are with this population. And you may be interested to know that the fact that the military has had a very difficult time recruiting among this population. One, because of the lack of high school, even for GED, and secondly, because of obesity. So that they were indicating that the health of these young people have made them poor recruits. And so from a health policy perspective, when you begin to hear that the military is concerned about the health of these young people and who they're going to get as soldiers, it creates sort of a strange bedfellow, but it also does give you an indicator of the fact of how does the health of young adults impact these very different kinds of stakeholders who are concerned about the health of the public. You can just see here that the level of male participation for African American has decreased over time, with the purple line being 1970, the blue being 2007. There's been an increase among the native-born Hispanics and even among the foreign-born Hispanics. And again, we could have a long conversation about why these trends are occurring. And a large part of it is, what are the economic opportunities? And in this conversation with representatives of the military, it was very clear that a lot of the signing up for the military stems from lack of economic opportunities, social disparities, lack of health insurance, and lack of ways to pay for future college and training opportunities. So when we look at what's happening with the demographic shifts and the participation here, I think it's an important consideration because it obviously has many, many health implications. Here's another population that received attention during the workshop, and that has to do with incarceration and the trends of incarceration. Again, purple is 1970, light blue is 2007, and you can see that among African Americans, even though clearly it's a very large representation, particularly around different geographic areas, that the proportion of African Americans has been decreasing over time, still too high, but it also is decreasing among native-born Latinos as well as foreign-born Latinos. And one of the projects that I'm involved in right now, just as a little bit of a sideline, is we've been doing a study of the DACA young people. DACAs are the Deferred Action Childhood Arrivals. These are the young people who arrived to this country before age 16, and as part of the administration's decision-making, maybe I will try to not be cynical in what I'm about to say, but as part of the election campaign strategy, these DACA young people are allowed to be in this country without fear of being deported for the next 2 years if they sign up, if they've been in education or the military or basically have been out of trouble. And the point I wanted to make is that we just finished 9 focus groups with these young adults. They're 18 to 30. We're also analyzing California Health Interview Survey data. But the point that I want to make is what a strong message these young people got from their parents to not be in trouble, to not get in trouble, not to be above the radar, to below the radar, in the shadows of what goes on in our society. So again, there are different reasons for these patterns and health implications as well. Another very important trend that I want to point out, this is a young man on the cover of a New Yorker with his parents hanging in the background, showing how he's putting his college diploma on the wall. And the quiz is, what proportion of young adults, ages 25 to 29, say that they live at home with their parents because of the economy? So the first option is 20%. Voters.
Is it what proportion of those that are living at home say they live at home because of the economy, or which? Oh,
that's a really good question. It's it really should be reading what proportion of young adults are living at home,
and say it's because.
And say that they're impacted because of the economy. 30%, 40%, 50%, 40%. So it's 41%. And in fact, over the last 5 years, we've gone from about 18 million young people moving back to home to 22 million young people. So that's not necessarily a bad thing. It is a major indicator of what's going on economically, that young people cannot feel or can't afford to be living independently from home. And it's much more of a pattern that you'd find in the European countries or in other cultures. And this whole thing about, oops, sorry. Young adults staying closest to home, you can see the patterns there too. Clearly earlier in young adulthood, 18 to 24, over half of them, particularly among young adults, are living with their parents because of the economy, and then about 41% of this age group. And then in terms of financial independence, you can also see that many of these young people are saying that financially they're not able to make it on their own, and that they need the support of their families. Just very briefly, I want to just touch on marriage and family formation. And then again, you can see that as we move into, that the percentage of women who have never married by education is becoming closer and closer over time, with marriage occurring about half of the time for those with college graduations versus those in high school or less than high school levels. For your tolerance with money. And then in terms of the married by race and ethnicity, that also has racial and ethnic patterns with also, again, the trend line is that there's more convergence occurring, even though there's more marriage occurring still among whites as compared to blacks and Latinos. And when you ask young people, why are you not getting married, a lot of it has to do with economic issues. And then we are also seeing that there's been a substantial increase in the number of young people having children without being married, among unmarried. And this is also, again, occurring across all ethnic and racial groupings. So before I move into sort of the health and the health conditions and access to care, are there any thoughts or comments that you'd like to make? Any of this data surprising to you? Is this sort of consistent with what you see among young people in your social circles or professional circles? I'm seeing a lot of body language saying yes, but I don't know, I just want to give you an opportunity to have any comments before I proceed. I'm not necessarily saying that this is bad or good. The results of the IOM will also not, it's just more that we have to be aware of how these trends are impacting insurance access, healthcare delivery, health conditions, and that's what I'm going to be turning my attention to now. So, clearly, I want to reiterate that many of the health problems that many of you are aware of are largely preventable, and that they're linked to behaviors and conditions with tremendous related outcomes, both during the adolescent and young adult years, as well as later. And while very few of this population have serious impairment, we need to recognize that this is a period in which a number of chronic health conditions, including and particularly important mental health disorders, really emerge. And that we need to be thinking about how do we train young people to manage these chronic health conditions? What kinds of incentives do we need to provide for providers and others to help young people manage some of these conditions that will be with them throughout their life? So this is a slide that reflects differences, because I do accept very much of a life course perspective, and I want to really focus on both the 15 to 19-year-old column as well as the 20 to 24-year-old to show you sort of the kinds of perspectives here. So in terms of morbidity and mortality, depressive disorders then is number one, but it happens sort of across all three, with issues of road traffic accidents and violence, as well as HIV, schizophrenia, bipolar. You can see from the last column how much and how many of these health conditions are impacted by mental health aspects. And from a health care system provision, one of the promises of the Affordable Care Act is that we will be having much more parity around mental health services. The challenge, as many of you know from working here in the Bay Area, is how difficult it is to get sufficient mental health support, counseling, and therapists, and a team approach in these areas, as well as long-term support for these young adults as they navigate their health. And many of these conditions clearly have negative health outcomes. So, for example, with injury-related behaviors, we know that the impact of trauma and disability that happens with sexual activity. There's obviously STIs, pregnancy, unintended pregnancy, and HIV, as well as from substance use, outcomes related to trauma and violence. And this is the reality that many of you face, sort of on a current and ongoing basis. So I just underline how important these issues are. I do want to highlight a bit of the chronic health conditions, given where I am giving a talk today, which has to do with the fact that we need to understand that there's also major gender differences between those who report a functional limitation for any condition, with females being somewhat higher than males. And the prevalence among of these conditions is important to also reflect. And you can see that asthma is represented here, and I know that there's several of you interested in this topic area here. 60% report this is a chronic health condition, and the longer or higher column, 20%, is obesity-related chronic health conditions. And in terms of past year mental health and substance use disorders, young adults by gender also have a variety of issues. And the yellow column here are males, blue are females, and the third column, well, the first are serious psychological distress, major depressive an episode experienced, as well as alcohol abuse and dependence, and drug abuse and dependence. And so again, these are things that are occurring, and the question is, how well prepared are our systems within primary care, within specialized care, to screen for these disabilities and to provide follow-up care, and what kinds of programs are most effective for these young people, because this does impact not only their health and well-being, but also their ability to get jobs, to stay in jobs, to develop economic independence. So where do young people go for care, and what do they get? This slide again, because I think it's important as we think about, not quite as big as I want, differences between adolescent and young adult health care. So with adolescents, most of the time you have an identified healthcare provider, usually a pediatrician. You have a financial system that's already in place. There's an organized structure for this kind of care. There's not a very high use of non-traditional sources of care, and oftentimes parents obviously play a very major role as to young people navigating healthcare systems. And what we find is that almost abruptly, when young people reach the age of 18, where they're no longer eligible, although I have to say with the ACA's expansion of age up to 26, this picture is beginning to change. And in fact, as many of you know, there have been over 3 million young people who are now eligible to receive health care benefits as a result of the ACA and early WIN. And a recent study that I saw based on what were the billing requirements, what were the way that the healthcare system was used, based upon one very large insurance carrier. 42% of services provided for this population of age of 26 who are now being covered by their parents pertain to mental health services. So the fact that when insurance is available and access to care is available, that these are the kinds of services that young people are searching for because of the important need. But the point we wanted to make with the Institute of Medicine's workshop is how there's really no identified healthcare provider that says, I'm a specialist in young adulthood. And the question is, do we need a specialist in young adulthood? Should the pediatrician's role be expanded to create expertise in the young adulthood? Because we all know that the transitions between middle childhood and adolescence into young adulthood become extremely complicated. And we've done a much better job with young people with special needs than we have with young adults who don't have a chronic health condition or a disability. We have no real financial picture yet in place, and hopefully optimistic about changes in the future. And what are where do the high users of non-traditional sorts of care for young people? We don't have very much a sense about where they're getting care, what kinds of care they're giving. But I will be sharing the little that we have begun to identify and understand. But clearly, many of the rights and responsibilities change in terms of not having the parents involved in being the ones who are orchestrating access to health care. And in fact, because of the tremendous concern about enrolling enough young adults in the ACA, because that is so important to get as many healthy bodies, healthy lives enrolled as much as possible. From what I understand, one of the major educational campaigns is being directed to mothers, the mothers of these young adults, because of the fact that, because I think I can see that some of the mothers who have young adults, children, can relate to what I'm saying. Part of it is that we can again spend a substantial amount of time debating why is this happening. Is it because we're coddling our young people and they haven't developed the navigation skills that in the past we might have had to develop? Do we have too many helicopter parents? Do we have too many lawnmower parents occurring that these young people aren't being able to cope? And if you don't know what the lawnmower parent is, I can share that. Helicopter parents, I think many of you are aware that this is the hovering parent who is calling up the college admissions director to be sure that Johnny or Jane have been able to get into the college, or if Johnny or Julio haven't gotten the right grade. We're now hearing of many more parents actively calling up on behalf of their young adult children. But lawnmower parents are the parents who are so concerned about their child experiencing any kind of diversity that if you think about an old-fashioned or even a modern lawnmower, they are mowing the grass in front of their child. So as the child and young adult starts walking down the pathway, there is no debris. It's all clean for them to come. And so we could have a debate about, are we damaging our young adults because they haven't learned some of the coping mechanisms? They haven't had the failures to deal with when they were younger, when perhaps some of the failures didn't have as much significance as they begin to have in the young adulthood period. But commenting here is that parents are actively engaged, and maybe that was true all the time, but it's becoming more visible because of things such as the cell phone phenomena and the role of technology and the ability to text your child and supervise your child and watch your child, throughout their existence. And, we don't know enough about, we haven't seen enough studies about what are the differences between socioeconomic groups around this hovering phenomena, but I have to say that the public images, the stereotype images, is that it's occurring much more among middle-class populations versus the parents who are dealing with 2 or 3 jobs and who don't have time to be hovering over their child. So the transitions from pediatric to young adulthood, and I know a number of you experience this, is that we need to be really thinking about the developmental appropriateness of moving forward, the coordination of responsibilities, to be thinking about how we plan for these transitions, not just among children with special needs, but all young people, and to be thinking about, again, if some of them are experiencing a special populations are experiencing chronic care management, how do we build that into our systems of care? And just to point out that only about 40% of youth ages 15 to 17 have received services necessary to make the appropriate transitions to adult health care, work, and independence. And this is from 2009, 2010. So this, again, raises a question about what would be supportive in terms of the transitions. Our family has been part of the Kaiser system, and so when our sons turned 18, we received letters indicating that they no longer were going to go to a pediatrician, with letters indicating that they were now going to be transitioning to an internist. And, you know, helping us as parents, help them identify who their new primary care doctor was going to be. I don't think that there are many other systems where that kind of transitional support is evident that I have come across. It's not a commercial for Kaiser, but it's just a small indicator of how can you begin to do some of that transition planning. And when we think about also care provision, we really have to be thinking about what do we have to build into the kind of counseling, into the kind of screening, into the content of care that's provided by a practitioner. How much screening is there for primary care? How much screening is there for special risk behaviors like tobacco use, like alcohol use? And I want to move into this kind of area. So this is a profile of what young adults really need, both in terms of preventive services, both in oral health care, substance use, nutrition, safety and violence prevention, as well as immunizations. Clearly, sexual health services is an important element, and then care for chronic conditions like mental health. And I want to indicate to you that one of the disappointments of the ACA is that for young adults, there is no dental care services. For children, it is built in, but this is one of those kind of battles where dental care is often left behind. It's one of those marginalized services. And a number of research projects or research studies point out how much this is an unmet need among this population. There are also guidelines for preventive services, and because I'm walking the bridge line between young adulthood and adolescence, I would want to point out to you that in the adolescents, Bright Futures does have professional guidelines around screening for high-risk behaviors, and that has been part of the ACA, as well as the US PSTF, which you're very familiar with, in terms of screening for mental health, depression, nutrition, exercise, obesity, alcohol, reproductive health, infectious disease, and domestic violence. And I would say that one of my career highlights was the opportunity to serve on the Institute of Medicine's committee that made recommendations around women's preventive services, and the fact that young adults and all women of all ages can access preventive services, including contraceptive care, without copayment. What will be very important as we really move into implementation is to see whether all FDA acceptable methods of contraception are covered as part of benefit packages, and whether really the quality of services that are provided are reflective of the guidelines and recommendations. Because we know that, in fact, many young people do not receive the kind of preventive guideline services. This is a slide that just indicates to you where young people, young adults, access care. And clearly, office-based visits is over half of them, but 15% are emergency department visits, and you can see that only about a third are receiving dental visits on an annual basis. About 7% of the hospital outpatient visits. Inpatient, 6% really represent oftentimes mostly healthcare, pregnancy, delivery, as well as the mental health and also trauma, violence, etc. But many of these young adults will report to you that they don't have a usual source of care. And it's also impacted by gender, with females more likely to have an identified source of care, even though 1 out of 5 indicates and 1 out of 3 young men indicate that they don't have a usual source of care. So navigating and sort of trying to figure out what's the best pathway to reach young people, and the concept of a medical home, and what does that mean for young people and what kinds of service composition is required, to me is one of the challenges that is impacting this population. Oh, am I going backwards? Thank you. Trying to, reach the 21st century. Sorry.
I think you may have to scroll through.
I think you have this, you have to
Yeah,
scroll that
just that
blue
line on the left there.
blue dot here.
Oh, yes.
Scroll that through. You were about 2/3 through.
Yeah, I was
so
2/3. Right.
So
Sorry.
I think you can.
I apologize, I'm not trying to get you to be, to have illness there. I know that I covered this, I didn't have enough expertise with games. Yeah, so you can see that I'm not technically as competent here. Okay, thank you. Thanks for the advice. Oops. Okay, great, yes, thank you. So you can see that ambulatory care visits occur, and that the differences here are that the 15 to 19 are on your left-hand side, 20 to 29 are in the middle, and 30 to 39-year-olds. And again, the point is that while females have an increase over time, a slight increase over time as compared to the adolescent years, it does decrease substantially for young men. And so again, the point of my showing information to you by gender and by age is the importance of thinking about how do we reach out to young men? What do we need to do in terms of outreach? How are we going to enroll young men in healthcare when they often think that they're young invincibles and don't need these kinds of services? Overall healthcare utilization, you can see for the 18 to 25-year-old, even though about 3/4 of them use services, it's far less than other age populations. And in terms of office-based services, tends to be less. Again, if you think about the morbidity, mortality patterns, having to do more with trauma, then you'd expect them to be using perhaps emergency department versus office-based practice visits. And here you can see the increased use of emergency department use for this age population, which is about as high as those age 65 and above, and those age 0 to 11. So I think of emergency rooms as an opportunity for early intervention as well. So how do we work with emergency departments to do some of the screening? So just to summarize, we have care from a variety of sources, but they usually lack an identified source. Females tend to use the services much more, and young men have lower use of services, but higher use of the emergency department. So what is it that they don't get in their health care? So this is a slide that I think is really important in terms of summarizing for you what were some of the access problems that these young people had due to cost. And again, we are at the verge of thinking about how will healthcare reform impact them. And the purple line here are those who are uninsured. The ones that are yellow who are insured now, but had some time where they were underinsured or not insured during the previous year. And the white lines are those who are insured all year. And I just want to spend an extra moment with them because the first column on your left is did not fill a prescription. So even among those who have insurance, 60% of them did not follow through to pick up their prescription. So we have to identify what were the problems with pickup of prescription. Was there enough coordination of care? What were the gaps? What was happening? But particularly important to be thinking about the second column, which have to do with skipped recommended test, treatment, or follow-up. With those without insurance, almost half of them indicating that they had skipped this kind of service. And half of those without insurance reporting that they had a medical problem, did not visit a doctor or clinic. And then about 40% not getting needed specialist care. So clearly the role of insurance, even though it's not a guarantee, plays a very important role in terms of patterns of healthcare utilization. And I want to also, because I'm emphasizing to you the importance of mental health, is that you can see that young people had also major problems in accessing healthcare services. The orange column is a female and yellow or so is males, and those with serious psychological stress, about 36%, only 36% received care, even though a larger number needed it. And those with alcohol and drug dependence also had a very small proportion actually accessing these kinds of services. Preventive services also, you can see that while they received blood pressure checks on your left-hand side, females being the yellow and males being the orange, there were only about 22% received any guidance about diet, 12% among males. About half of them received some information about talking to their providers about tobacco use, and again, gender differences in terms of healthcare utilization patterns. This is a slide that shows you what kinds of preventive services young adults receive. And the role of primary care and the role of OBGYN. So I just want to highlight the very top column, which has to do with, did any of them receive preventive services? And primary care and OBGYN are similar here, but you can see lost opportunities for accessing and screening and providing at least early intervention kind of work, whether it's mental health, whether it's weight reduction, whether it's smoking and exercise. And so a point of this workshop was very much about where are those opportunities for earlier intervention. So summary-wise, obviously insurance really matters. There's an unmet need for many of services, particularly mental health, and preventive screenings are very low for this population. So there are many shortcomings in the current system of care. This is not shocking to any of you. We've had such perverse incentives around the fact that the system rewards much more expensive care over in comparison to preventive services or chronic disease management. There's clearly a gap in the numbers of providers that are available, particularly around mental health, and that the financial system is very difficult in terms of accessing care. And one of the things I am very worried about in the next few months is how will the navigators who are signing up young adults as well as other age groups really work with young adults to really figure out what the best insurance coverage is? Will they have enough support and guidance and overcome their concerns about spending too much money on health benefits at odds with other expenses given their financial profile, even with the supplements of premiums by the federal government. So I've mentioned to you this abrupt change at age 18, and that there really are very few models of effective transition to adult health care. Some of those models that are most effective have been in the area of children with special health needs, but we still have concerns about how do we bring together the legal status of this young population and the fact that oftentimes they lose eligibility for many of the public insurance and, up to now, their parents' benefits. And clearly we still have a lot of challenges in terms of what are the settings that are best for this population. What would be the best way to reach out to them? Do we need to have a pathway where there's no wrong door? That is, they come in one pathway, perhaps through a college or a community college healthcare system. How does that system interface with a primary care system to which they will go to after they graduate? And we clearly need to be thinking about, especially vulnerable populations, for example, young people who are living in foster care. And I think that one of the real spotlights or expectations of the ACA is that young adults who are leaving the foster care system will have expanded health insurance coverage beyond age 18. Those who don't graduate from high school, homeless, are in the justice system, or who have chronic health conditions, we definitely need to be thinking about how do we even improve the delivery of health care to these populations. And clearly, mental health services are important in terms of thinking about how do we reimburse for these services, how do we deal with coverage, will there be enough numbers of visits available. Right now, there are huge high co-pays, very few limited visits. How will the benefits coverage intersect with these kinds of needs that I've identified? And in terms of the systemic issues, just in terms of the fact that it's complicated to navigate healthcare systems, and even in adolescence, when there are parents, sometimes it's very difficult to help educate young people about how to use the system effectively. Clearly, the focus on acute care rather than prevention and primary care management has been very prevalent in for this age population. And there's an expectation that electronic medical records and the use of social media, the role of having the capacity to have a patient portal where you are communicating with your provider has great promise for the future for this population. So our hopes for the ACA are that there won't be exclusions for pre-existing conditions for this population, that there will be major expansions in terms of reaching these populations, and we are very lucky to be living in California, where we are a state that is going to expand Medicaid coverage, and to be thinking again, what are essential healthcare benefits for this population? Will they have sufficient healthcare services that this young population need? The point that I'm trying to underline here is what's the disconnect? Is there going to be a continuation of the disconnect of the way that we've set up healthcare system with the kinds of services and needs of this population that I've been pointing out to? So in summary, there are a variety of risky behaviors and health conditions that peak during this period. There's an unmet need for prevention and mental health services. We need to be thinking about that smooth transition and to be thinking about what does medical hold mean for this population. So I want to move into just to make the point. You don't seem to get there, but I like that slide a lot. It just it's a fork in the road.
Claire?
Yes.
One thing you didn't really mention here that I see as a big burden in this age range is just the administrative burden of health care, because this is an age where kids don't have stable jobs, and their living situation is changing, they're moving, and our healthcare system serves a group like that, I think, worst, because you don't have a stable situation. Even with the extension to age 26, I noticed that I just had to fill in a multi-page form to get the health insurance at college waived, because we have insurance, and it was a total no-brainer. We have Kaiser, he's going to Davis, Kaiser's there, but I had to call Kaiser to get help to fill in this form. I think of all the kids who are having to pay $1,500 because they couldn't fill in that form, for their health care insurance. And I think of the administrative burden at the college of figuring out for tens of thousands of kids whether the insurance they have is adequate, and whether they have to charge them this extra and get a collection agency to get the money and everything. And I think, that's sort of a problem systemic in our whole healthcare system, but maybe much even a bigger issue here in this age range. I don't know.
I'm really glad you brought that point up. It wasn't a big part of this Institute's of Medicine workshop per se, other than to acknowledge that the systems are so fragmented, whether it's filling out paperwork, whether it's the duplication of medical records, with lack of interoperability between systems of care, the fact that oftentimes adolescents and young adults don't have an identified, particularly young adults as they transition into college, don't have that identified medical home. And how does that medical home coordinate services, including billing and including administrative charges and including interfacing between college and
Right.
school? So
When you think of a Canadian student going to college and all the healthcare issue they would have to worry about is finding the doctor they want to visit in the town where they're going to college,
Right.
getting the care for what they want. Whereas for here, all the emphasis is on totally things not related to healthcare, but related to paperwork.
And
I don't-
it's a large part of the huge cost of healthcare in our system. Especially if you weren't there to be this orchestra conductor and
Right.
assisting your young person, he or he has enough other things to deal with as they're dealing with getting familiar with their new life at Davis or
Right.
wherever they are. So I'm hoping that when we have accountable care organizations, and I don't know if I'm trying to be too idealistic, my age group we would call Pollyanna. I'm looking for a 21st century equivalent to Pollyanna. But just sort of the fact that when a system is going to be responsible, and you've shared with us that you're part of Kaiser, I mean, there are incentives to keep young people healthier, all patients to be healthier, to be sure that you're getting your screening test, to be able, to get the labs on time, to be able to communicate with your doctor effectively through email, and to be able to look at your medical record. And one topic that I did not move into here at all, just has to do with issues of confidentiality, which isn't exactly your point, but there are still concerns about young people not accessing health care because of concerns about the fact that even up to age 26, if you think your parents are going to be able to look at the electronic health care record, is that going to discourage you from going to the same system in which your parent has oversight of your electronic health care record? But the point that you're raising is really excellent. I don't see an easy solution, and I don't see that the introduction of the ACA is going to solve that overnight. I think it's going to take a very long time. And my worry about the American public is the lack of tolerance about recognizing that we're introducing a very transformative piece of legislation. The analogy I make often is to making waffles, and how your first waffle tends to be horrible and it's all scattered. But you see headlines from today, the Republicans are trying to, for the 42nd time, eliminate funding for Obamacare without recognizing, and they're using tactics similar to death panels to divide the American public. Instead of saying, you know what, we have almost 45 to 50 million Americans without health insurance. We're paying for this health insurance, lack of health insurance among this population throughout the country. So we pay either now or, pay now or pay later. But I'm not optimistic that we're going to solve this dilemma until people have the financial incentive to be able to say, let's look at what coverage does this family have, and where should the delivery of care happen, and what's the relationship between College Health and Kaiser, for example, if Kaiser wasn't available in the local. So I just want to underline some implications here in terms of clearly the proportion of Latino and Latinas is going to continue to be a substantial aspect of the future, and so I follow, immigration policy with great attention, not only because of personal interests, but the impact in terms of when you think about how many Latinos are going to be left out of healthcare reform, even those who are here legally less than 5 years. We need to be thinking about what are the kinds of pipeline choices that we make in terms of working with young people as they think about the fact that many of the young people have limitless choices. That is, they can go many, many different options. They can delay the 5 milestones. They can create their own milestones. But we have to recognize how many young people in our society are really marginalized and left out of those many different kinds of options, and the importance of education and employment in being able to provide more equity in our society. The fact that our educational system has been so extended, meaning that not only is it not even only just high school graduation, graduates, but graduate school becoming an important kind of economic means to having better jobs, and what the impact is on marriage and family formation, as well as differences in terms of gender, with more women going to college. How does that impact gender relationships as well as marriage decisions? We need to be thinking about social policies related to training programs, to be thinking about issues such as long-distance learning, maternity leave, and a variety of other social issues that affect family formation. Sorry. I just want to make another point about just the fact of how much the economics of our country impacts its population. It's not a surprise to any of you, but we need to be thinking about what are the kinds of employment, training opportunities for those young people who don't necessarily go on to college. What are the kinds of employment, training programs? How do you incentivize private industry to be working in this area for, again, having the financial means to improve the lives of these young people? So in terms of thinking about next steps, you'll see a real interest in thinking about what is the importance of our understanding. Understanding what young adults want and the decision-making process related to healthcare. There's a big question about will they access healthcare or not? What are the kinds of discipline-specific trainings that we need for our clinicians and our providers in all sorts of different disciplines in terms of treating a 21-year-old differently from a 41-year-old. What are the services that we need to improve for vulnerable young adults, as well as smoothing those transitions? And then really thinking about how electronic and social media can begin to be used to enhance service delivery, health promotion, as well as prevention services. So I want to finish by thanking my co-authors of this presentation and to open it up for additional conversation and dialogue.
Thank you, Claire, that was terrific. So questions, comments, discussion?
Lisa.
That was a great presentation. I'm sorry I missed part of it, but I have two observations. One is, for those of us who are safety net providers, we see a lot. I have now almost 5% of my panel are young adults with very special needs and who have aged out of the other system, and there's no one and there's only one provider who's trained to take care of them in our system. She's full. So I'm taking care of them because they are Spanish speaking, they were sent to me, and don't have the training to do that. And I do think that the special, for safety net providers, the special needs population, and for example, or the post-trauma, post-gunshot wound, which I have two of in my panel, that's a huge population that needs to be looked at really differently from a disciplinary and financial point of view. So I'm really glad that you keep coming back to that in your presentation. This is more common. On the other hand, from a general internist point of view, I feel perfectly competent to take care of a 19-year-old without special needs. And I wonder if my pediatrician colleagues feel comfortable. And I also wonder about the role of family medicine and how much we shy away from promoting family medicine. So I can't, in the healthcare system of the future, I think I would love to have more young, healthy patients because I'll get through them faster. But I also think that from a disciplinary point of view, I don't see creating new specialties, but I do see supporting family medicine. What are your thoughts on that and the politics of all that?
So I think you raised very important issues about the role of family medicine, the role of internists, the role of pediatricians, and there was no advocacy in this meeting about any one particular discipline being better than another one. But it was recognizing, number one, the complexity of some of these issues, of the medical issues, not only the young people with special needs, but also comorbidities of young people who might have a mental health issue and dealing with obesity and dealing with perhaps something else. The other element was, what are effective interventions with this population? So the question is, what do we know about obesity prevention among this population, or tobacco prevention, or the third element really had to do with how do you help young people navigate healthcare access. And it wasn't that the perception was that it's only MDs who have the monopoly of providing care, that there is a tremendous need for team building. And again, this is something that most of us wouldn't have. There's no controversy in this room about the need for social workers and counselors, as well as nurse practitioners and PAs working in the healthcare system. The concerns are, do we need to pay some special attention to this period of transition where some of the lack of stability? We know, for example, with adults that if you have family to help take care of, help you in being compliant with using medications or picking up the prescription. But if the young people are living by themselves or living with a whole bunch of other people and not being compliant with a medical regimen, what would be supportive of that young person so that we don't burden you as the primary care doctor or internist or specialist? And can we begin to expand the kinds of healthcare supports that are needed to help young people stay healthy and well-being while also managing a chronic health condition or just preventive visits, or just preventive care services. So I think we were looking at the fact that we want to raise awareness, we want to raise consciousness of some of the special needs that occur when it's not that you're going down this nice little pathway. You're confronted with all these different options. Other comments? That was great, thanks.
Let me make a comment. As part of the presentation, you mentioned that because of the economy now, more young people are moving back home.
Yes.
But I think the flip side to that is possibly a positive thing, because you now have more of a support structure to take care of the health issues, even though, from the economic standpoint, it's a negative point, right?
I think it's a very good point. The question or the issue really is for, what are the positive outcomes of having young people move back home? Is there more resilience, protective aspects of this, family formation? And many cultures have that as part of their, the value system. So it's not that it's so unusual. It's this disconnect, I think, for the American public, which has often valued independence and placed priority on the fact that you're not fully independent until you are financially able, until you have your own place, of living, your own relationships, etc. So in this re-education, redefinition of what normal is, there are a number of issues, and we hear, and I haven't seen the IOM committee did not come across major studies on what the impact has been of families being reconstituted in this manner. And in fact, in other cultures, it's been very, very protective and very supportive. So there may be a new movement to that. It does not negate for me, I still feel, the importance of thinking about confidentiality and protection and having, medical records that if you are on your parents' plan, does that prevent you from getting an STI check or some other kind of lab? And to be thinking about, and in fact there's a bill on the governor's desk that I hope by mid-October he will sign, which has to do with explanation of benefits, EOBs, that would be sent to the policy holders to say this person received this lab test, and the law that is being proposed is that for any sensitive service, whether it's mental health, substance use, reproductive health, that the EOB would not be sent to the policyholder, it could be sent to the person who received the services. And I want to say that EOBs were established because of the concerns about fraud. You know, there's a real cause, a real reason why that policy was established. But where I see a potential confrontation is the importance of navigating state laws that protect confidentiality from systems such as health insurance coverage that requires EOBs and the potential conflict. And then what happens to a young person in that, you know, caught in that disconnect. And again, I want to say parents are very important. Many parents do know that their child or their young adult is receiving reproductive health services. It's not that I want to say that all parents, you know, would be shocked to find out that their child is sexually active, especially when he or she is a young adult. But there's still a stigma and there's still a concern. And I also don't want to leave you with the sense that I'm only speaking about young adults. I mean, I think about women of all ages or men of all ages who may be in a situation where they don't want to let their partner know that they went in for an STI check of their situation, or might be in a domestic or intimate violence situation where they don't want this kind of data to be shared. So there are many, many factors that are in play, and I see that over the next several years, I'm hoping that the governor will sign this piece of legislation, that will impact not only California, but states throughout the country, because oftentimes we've been the progressive state that other states emulate, but clearly we have a country that has a large amount of polarization, and only half the states really allow adolescents free access to confidential care. There are many states that allow confidential services only for very special segments of the population. So we are a long way from that kind of access.
So this thing about benefits, this is to make sure that the person who has the insurance knows what's being charged, right?
Right, and that services were,
I think,
and
like,
that services were delivered. Part of it is
Yeah.
explanation of benefits, meaning that you did receive the
Right.
health care, and it wasn't someone else who was using.
right. My parents deal with this with their health care, but it seems to me at Kaiser you don't have this issue at all because there's no billing of anything, right? You just receive the
But some-
services. Nobody gets informed of what services.
In Kaiser, it depends upon the benefit, what insurance coverage you have under Kaiser. Kaiser isn't like one policy under Kaiser. There are people
Yeah.
who have co-payments under the Kaiser system.
I see. And
And
then
they
it would
would
be an
receive
issue,
an
yeah.
EOB.
Because they're very careful, it seems to me, about this confidentiality issue, even teens, not just young adults, but as soon as your kid is a teenager, they make it clear that they have direct access to the physician and that you as a parent do not have that unless the child requests that you do.
So Kaiser in Northern California in particular, since the year 2004, has been extremely careful about the issues of confidentiality, building into their electronic healthcare record this issue of keeping confidentiality from the parents. But they also spend time with the parents, explaining to them, I don't know if you have this experience, I have that experience where they do explain to you, they try to build into the medical visit as the youngster reaches ages like 15, 16, 17, and 18, something that's called time alone,
Yes.
which is a measure of giving the young person several opportunities. One, the opportunity to create a relationship with the doctor or the nurse practitioner or the PA on their own, because clearly we're trying to enable young people to be independent consumers of healthcare. Secondly, so that there is that time to build trust. Secondly, just to develop those kinds of skills. How do you communicate with a doctor if you're 15, 16, or 17? And third, obviously, to be able to disclose information that you might not want to have a parent present.
Right.
Now, oftentimes during that visit, the provider will ask the parent to leave the room, but will also come back and say, you know, or provide opportunities for the parent to ask questions. At least that's what the ideal is,
Yeah.
and oftentimes I think that's what they strive for.
Yeah.
They have also built in a lot of in the system so that even when the person sends an email for electronic healthcare record or calls up appointment to find out about whether they, for the sensitive services, they are able to access care without parental consent. But that's not true of all Kaisers, and it's not true of, systems have not been set up in all Kaisers, like in Ethiopia, then, the system in the East Coast, they have not created the same kinds of principles out there. But I'm actually doing right now a small study of various stakeholders related to New York State to identify best practices around this reconciling of EOB, confidentiality, and what are some of the policies that can be put in place for checks and balances. We had a terrible situation about 15 years ago at UCSF where EOB was sent home after an adolescent came to Parnassus Hospital for STI check, and the parent found out and the child committed suicide. So this is clearly a very, very important issue. And ideally, we would love to have parents who are, informed, who are educated, who are part of their young person's decision making. But there are also adolescents who fear that they're going to disappoint their parent if they're involved in, sexual activity or substance use, or have a depression that they don't want to share with their parent because fear of failing them as their child.
It seems like there's a whole network of dependencies that our healthcare system imposes on us because we're all dependent on our healthcare to somebody else, like a parent, an employer, whatever. And if our employer finds out that we have things,
Right.
I mean,
Right, and there's something.
it's just the nature. If we had an independent healthcare system where we each had independent access, then it would be easy.
We're with you, Pam.
And I was going to say that, that it's ethical issues. It's also, I'm finding, there's something called data segmentation. So within the electronic medical record, you should be able to say these areas are protected and not going to be covered. And it's done most effectively around mental health services. And at the same time, there's a challenge in terms of mental health and primary care or physical health, being able to communicate about those issues. So I think that we're at a sort of a crux of what types of information do we need, how do we protect the consumer, how do we protect the consumer against their employer. And then there's also this whole revolution that's taking place around what data, like for example, with genetic testing, and the fears of if you have something in your medical record that says that you have a higher risk for something, is that going to impact? Even though now under the ACA, pre-existing condition is usually considered an illness, well, will that cover also genomic testing?
That's great. Thank you very much, Claire. This has really been a fabulous.